Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a patient who attended reporting bilateral blocked ears, and this is their left ear that we're commencing with. And in this ear, their occlusion is quite dry. It's not only earwax but a lot of dead skin, keratinous skin, and as you can probably see, the ear canal is quite inflamed. So they're suffering from superficial otitis externa. Otitis externa is an umbrella term given to an infection or inflammation of the outer ear. And the outer ear is made up of the cartilage that looks like a satellite dish on either side of our heads, the ear canal, and also the outermost membrane of the eardrum. So the eardrum has three membranes, and the outermost membrane, so the lateral membrane that's facing towards us, which is visible, is made up of the same skin, the epithelial skin cells that lines the inner 2/3 of the ear canal. So if any region of that section of the ear is infected or inflamed, we would label that as otitis externa. And in this case, it's probably more superficial. There's a bit of inflammation at the entrance. So the ear canal's a bit narrow, so I'm just using the suction probe and the endoscope to stretch the ear open. But as we go into the ear, there's no massive amount of swelling. I think in this ear, the inflammation at the entrance is because the patient was experiencing a lot of itchiness, so they're rubbing the entrance of the ear, hence why the ear canal is slightly swollen there. But inside the ear canal itself, there's no evidence of what we call deep otitis externa. So that's when the dermis layer, so the middle layer of the skin that lines the ear canal, or even sometimes the subcutaneous layer, so the third layer of skin. So the skin that lines the ear canal, it's different on different sections of the ear canal. So on the outer third, the cartilage portion, where we are now actually, the skin here is about 1 millimeter in thickness, and it contains three layers. You've got the epidermis layer, which is the outer protective barrier of skin, and that's about 0.2 millimeters in thickness, there or thereabouts. Underneath that, you've got the dermis layer, so that's the midsection, and that's where you find the hair follicles, which you can see these hair strands protruding outwards from the dermis layer on the cartilage portion of the ear canal. And then the innermost layer is the subcutaneous layer, which is a layer of connective tissue and insulating fat. Once you're more than a third into the ear canal, so on the bony section of the ear canal, you've just got the epidermis layer, which is the outermost protective barrier. So the skin that lines the bony part is extremely thin and delicate, hence why the bony part of the ear canal is very sensitive. If you've been watching my videos over the years, you know I stress that point. So if we're working on the cartilage portion, because cartilage is a bit more flexible than bone, you've got a thick layer of skin as well protecting the cartilage, we can apply a bit more pressure. But when we're working on the bony part, deeper in the ear, we're just going to be really careful. So I've just put some oil in here to lubricate this. I've used a bit of suction, just using the ear hook, trying to get in and behind. The ear is quite bendy as well, so when we insert the hook, I've just got to be careful that I don't inadvertently go close to the side of the ear canal walls, because we don't know what's behind this wax. Occasionally you can have some surprises. You can have an extreme narrowing, so stenosis of the ear canal, so the bony part of the ear canal really narrows, and if you're not careful you can make contact with that with the ear hook. You can have exostosis, so also known as surface ear. That's when the 12 o'clock of the ear canal, on the bony part of the ear canal, about 4 o'clock and 9 o'clock, you get bony spurs, so you can make contact with those. And they are somewhat similar to osteomas. Osteomas are more singular bony spurs, as opposed to surface ear, where you get this arrangement. You normally get 3 or 4 in that 12 o'clock, say 3 or 4 o'clock and 9 o'clock position. With an osteoma, you can find one in isolation. So you always got to be careful when you can't see the inner depths of the ear when you're using hooks and scoops and forceps, that you don't inadvertently come in contact with it. So I've just cleared up the residual wax skin on there, and that ear looks healthy enough. Now in this ear, the patient had been using drops to soften the wax, and they informed me that after putting the drops in the ear, what they did, and the instructions are not very clear on these drops when you read the instructions for use, they just tilted their head across, so the ear that they put the drops in was facing towards the ceiling to allow the drops to penetrate deep in the ear, and they left it there all night. And what actually happened is that this wax and dead skin had got softened, and once it had got softened, it just drizzled further down towards the eardrum because of gravity, and it made it quite difficult to remove. They also used drops that I'm not very keen on. It's hydrogen peroxide based drops, and the reason why I'm not keen on that is, well, twofold actually. It's water based and alkaline, which some people can get a bit of irritation against. In addition, it turns the wax like mashed potato. It's very hard to vacuum, and when we're this close and deep into the ear, when you've got wax on the canal wall, you can't really use an ear hook or Jobson horn. You're going to have to suction this out, because again, you're going to otherwise make contact with the bony part of the ear canal, which will be uncomfortable for the patient. Now you can just about see some of the eardrum about 7 o'clock, 8 o'clock, and the lower section now. So I did put some olive oil spray just to help to change the consistency of this wax. So whenever you're using drops, if you're using drops, the way I recommend to use drops is 2 to 3 times a day. Fill up the ear, so you can be a bit generous. And I typically recommend medical grade olive oil spray. We actually sell some. It's a company called Clear, so I'll just declare any conflict of interest. I am their healthcare advisor, so I work with them, and we're developing other ear care products. But you can use any medical grade olive oil. If you're in the UK, you can actually purchase it from our website. If you visit our website, the URL's there. Visit our public shop and you'll see it there. With medical grade olive oil, as opposed to home olive oil, the filtration process is more natural, so there's no chemicals involved, hence why medical grade's a bit safer. It's got less impurities that may possibly trigger infection, so that's why we recommend medicinal olive oils, and in a spray format it's easier to apply. And the reason why I recommend olive oil is with earwax, once you've got occluding earwax, whichever drops you use, it's not going to dissolve the wax. That's the misnomer. You may see it on packaging that it dissolves the wax. Nothing is going to dissolve wax. For me, the word dissolve means it disappears. Now, it can break down wax, so you can disperse it and break it down. So drops like hydrogen peroxide drops, sodium bicarbonate drops, but it's still going to be in your ear. It still needs to be removed. So as a softening agent, I prefer patients using olive oil spray because, one, it's acidic, so it's a similar pH to the natural pH level of the ear, and retaining that slightly acidic pH in the ear is very important because it helps to fight off any harmful bacteria and fungi, and it's non-water based. So again, if you've been watching my channel over the years, you know I'm not a big fan of water entering the ear. In fact, I had 2 patients today who developed Otitis externa, a swimmer's ear in this case, due to water getting into the ear, and that's because they had irrigation performed. So there's always a chance. Now, I would say, I think the data suggests that if you have your ears irrigated, it's like a 5% chance of developing Otitis externa. So unfortunately, we don't know which 5% of the population is going to have adverse reactions to irrigation. And in terms of microsuction, I think the stats, it's significantly less likely to get an infection. You're looking at less than, I think, 0.1% or something like that. So it's very low chance of getting an infection with, in comparison to getting water in your ears. So yeah, put the drops in your ears, the olive oil spray. The only time I veer away from olive oil spray is if you're suffering from keratosis obturans. Now, I won't explain in detail what keratosis obturans is. There's a playlist on my YouTube channel. You can visit the playlist of keratosis obturans, and you can see all the explanations there. But essentially, it's not earwax; it's a dead skin plug. With that, quite often that needs to be pre-treated prior to removal, and that I'd recommend sodium bicarbonate drops. It just works a lot better at breaking up that skin in comparison to olive oil spray. So that's the only time I'll deviate from that advice normally. So put the drops in your ears, tilt your head across so the ear that's got the drops in is facing the ceiling, So that allows the drops to penetrate deep into the ear. Let it sit there for 4 to 5 minutes or longer if you can. I wouldn't do any more than 10 minutes though. And then after that, you should just tilt your head in the opposite direction. So the ear that was once facing the ceiling is now facing the floor. And just place a tissue beneath your ear to collect all that oil or whichever drops you're using. And that prevents the softened wax drizzling further down the ear canal towards the eardrum. And if you want to use the olive oil as a preventative measure, and I can't guarantee that it's going to stop the earwax from forming, some evidence that suggests that it does, some evidence suggests that it has the opposite effect because the oil can add another veneer, another layer of oil onto the wax plug if you've got wax. But if you use it on a regular basis, there's potential, like just say you have a little bit of earwax in the ear and you're putting some drops in to soften it and then you tilt your head in the opposite direction and you're draining it. You're almost washing out your ear using olive oil. So it may work, it may not. But the key bit is in both circumstances to drain the ear. So when I mean drain the ear, not to rinse it, don't get water in there, just drain it, allow the ear to naturally disperse of the oil. Now I've cleared the occlusion, the patient can hear much better. You've got all this sticky wax keratin on the drum. We're just going to hover over, we're not going to be silly. There's a bit on the hammer bone itself, so we're just going to be careful there because if you do make, you can see just to the right of the suction probe, that's the hammer bone. And you've got some wax. Now that hammer bone is attached on the underneath side of the eardrum. You make contact with that, it can be uncomfortable for the patient. So I'm just hovering over the eardrum. So there is going to be a bit left, so don't send me any harsh words, please, or emails that sometimes we do get. I don't want to perforate the patient's eardrum, and I just hovered over. If I did any more, it means me really penetrating against the drum. So this bout of wax is not really going to cause any issues. I mean, I do get a lot more out, so it's going to be a bit cleaner. Just put another layer of drops just to see if it can just soften this sticky wax keratin that's stained on the drum. Now, what will happen, because the occlusion has been removed, the skin that, as I mentioned earlier, that lines the ear canal, the inner 2/3, also lines the eardrum. And from the center of the eardrum, this skin will start to move sideways. And as it moves sideways, it will naturally, the wax that's on the skin on the eardrum at the moment, in a few months, that skin will be probably halfway down the ear canal. So you'll have a fresh layer of skin on the eardrum. So the ear canal sheds itself from the center of the eardrum. So the skin cells in the ear, they undergo a process called mitosis. So you get cell division, which creates a daughter cell, and the daughter cell then pushes the parent cell forward and away from the base of the ear canal. So as that parent cell is pushed further and further away from the blood supply that's in between the bone and the basal layer of the skin, it undergoes a process called cornification. So that those skin cells, 70% of these skin cells will, as they reach the surface of the ear canal at the furthest distance away from the base of the ear canal, it's got poor vascular supply. The cell almost self-destructs. It dies, all the organelles within the cells die, all the intracellular fluid, it's pushed out, and instead that skin cell, that dead skin cell, produces keratin. So keratin is a protein. It has some very useful benefits. It's water repellent, so it provides a protective layer in the ear canal, so it prevents external water from macerating the skin within the ear. Also, keratin helps to reflect harmful UV rays. And keratin is a protein that's also found on our fingernails and on our hair strands. You get different types of keratin, but we do normally find it on the surface of the outer skin that lines the ear canal. Not so much. So the skin that lines the inner section of the eardrum and the middle ear, you don't get any keratinous skin there. That's more mucosal skin. So mucosal skin is similar to the skin that lines the inside of our nose. So it's more secretory, you can get mucus secretions, whereas the skin that lines the ear canal doesn't produce those same secretions. So it's just a bit of a puddle of oil. You can see how I've bent the tip of the suction probe, and that's to avoid contact with the front section of the ear canal, the anterior canal wall. That part in particular is very sensitive, and if you catch that and graze that, it can be quite painful for the patient. So I think I'm happy with that. There's a bit of staining around the edge, but as you can see, we've done everything we can try to remove that. And there's a point where you think, quick while to ahead, because we don't want to cause any trauma. I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.